Hello, everyone. Welcome. My name is Nathaniel Brooks. I'm from the University of Wisconsin in Madison. We're here today for a NASS Ask the Experts session. I'm here today with Dr. Michael Steinmetz of the Cleveland Clinic and Dr. Khoi Than of the Oregon Health Sciences. And we're going to be discussing the topic of mobile spondylolisthesis and in the lumbar spine and its treatment options. So what I want to really do is set up with you guys kind of the case scenario. This is a patient who has an L4-5 spondylolisthesis. It's causing an L4 radiculopathy. That's their main clinical symptom complaints. We find on dynamic imaging that there's mobility, about a grade 1 to 2 slip of L4 and L5, and severe foraminal stenosis. When the patient goes into a supine position, it reduces almost entirely back to normal, and their symptoms resolve. So the scenario and really the question today is what are the available treatment options, both surgical, non-surgical, and how do you approach this type of patient? So I'd like to start with you, Mike, if you don't mind. What do you do in this type of patient really for a diagnostic workup or anything like that to try and make decisions about what you want to do?
Excellent. And I think you've presented it in a way that we have a lot of the diagnostic imaging, but I think if we even take a step back with a patient with spondylolisthesis, I do obtain at least standing x-rays. I'm not sure, we're going to hear what you two do, but I've not found a huge difference between a standing lumbar x-ray plus a flexion extension x-ray. So typically what I would do is look at my MRI if it's reduced, but perhaps I'm suspecting a spondylolisthesis, like maybe the symptoms are only with standing. There's not a lot of compression on the MRI yet. I could see a lot of gapping in the facet joint, T2 signal facet. I'll then obtain a weight-bearing x-ray and look for that mobile spondylolisthesis. And what I've seen, at least anecdotally, is usually you'll pick that up with just weight-bearing. So I don't typically get flexion extension lumbar x-rays, just a personal preference. I'm not sure if it adds too much in this patient population, but I would pick up the spondylolisthesis with that. I still think, though, with you have at least articulated a patient with an L4 radiculopathy, and often you can tell that based on where their symptomatology is, but sometimes there's overlap. So I probably still would perhaps send them for a diagnostic injection just to confirm that indeed I'm at the right spot and feel very comfortable that I've worked this up completely. And so if I've got a good injection, I see the dynamic aspect of the spondylolisthesis. Clinically, they have a radiculopathy in the L4 dermatoma. I'd feel very satisfied that this is the cause, and probably would quit diagnostic workup at that point.
Sure. And Khoi, what do you think as far as diagnostic workup for this type of thing? Do you typically do weight-bearing films, flexion extension films, or?
Yeah, I agree with a lot of what Mike said. For this type of patient in my practice, they'll generally come in with an MRI. Prior to seeing them, I'll get full-length standing scoliosis films just to understand their overall spinal balance and make sure that I'm not missing anything else from a deformity standpoint. I'll generally get flexion extension films, although I agree a lot of times the films are of low quality and not much difference is seen between flexion and extension. I generally rely on clinical diagnosis and do not send them for a diagnostic injection frequently, although we'll always send them to try non-operative therapies first, such as physical therapy and perhaps a therapeutic injection.
Khoi brings up a good point. I think that we should probably stress the idea of getting scoliosis x-rays, which is when we get a weight-bearing film, it typically is a 3-foot film to look at the scoliosis x-ray to look at the overall spinal alignment. It's important, I think, when we evaluate them, but also if we plan an operation, is what is their spinal pelvic balance? Do I need to have, or surgically, do I need to change it at all? Do I need to make sure I maintain it? So I think that knowledge ahead of time is critical. So I just want to back you up on that. That's something I do as well.
So another part of this scenario I think is valuable, and Khoi touched on it, is that there are some times where the patient will come to your office like this and they definitively have the symptoms and they definitively have a mobile spondylolisthesis, and yet the insurance company still asks you to do six weeks or even 3 months of physical therapy. Do you think in that scenario there's really going to be value to that in the end? Or have you seen a patient with a mobile spondylolisthesis get better with therapy in a long-term way?
Well, I think Oftentimes when we see them, it's a little bit more end stage in the disease. I think they do improve with physical therapy. We see improved core strengthening, improved endurance, improved walking, ability and duration. Often, again, I think in my practice, usually I'm seeing them in that end stage, so it's hard to say that I'm seeing someone that has symptoms have gone completely away, but with physical therapy. But I certainly have seen some that have done that. But I think it's incredibly helpful, and it does help prepare, in their overall management, and also if we're going to operate on them, it does good for them.
And Coy, what do you think in those scenarios? Therapy, you'll typically do it for a defined period of time, or will you, depending on the films, those kinds of things, decide?
Yeah, as Mike alluded to, and especially in Oregon where I practice, we have a lot of trouble getting surgeries authorized by insurance if patients haven't been through an appropriate course of non-operative therapy. I think the SPORT trials looked at spondylolisthesis patients and did find some improvement in the cohort that was treated just non-operatively, although not to the same extent as those treated surgically. Anecdotally, have had just a handful of patients probably who I sent to non-operative therapies, and they improved to a point where they were no longer interested in surgery. But I agree that the majority likely end up needing an operation at some point.
Okay. We're going to switch questions and talk about just goals of surgery in these types of patients. So if either one of you can start, but maybe with Mike, just to switch back and forth. When you're thinking about doing this type of operation, what do you, especially when you're teaching residents and stuff, what are you teaching them as goals of the operation?
Sure, and I think we've seen this change over time, which is interesting when we look at operating on this problem. I think if you go back in time, or go back, a decade or 2 decades ago, often this is treated with a fusion, instrumented or non-instrumented, but the goal of that operation was simply decompress the nerves and obtain a fusion. And once we obtain a fusion, you had a satisfactory outcome, and that was it. I think today the goals of this operation would be to, one, decompress the nerve. That's all this patient needs, right? Just needs nerve decompression, and their symptoms are going to go away. That's their only complaint, essentially. In the case you present, it's interesting in a sense that it could be done directly by removing bone over the foramen, or indirectly by just the patient's reduced and hold them stable with say a fusion. So that you could look at this either way with regards to how you do the decompression, but we need to decompress the spine directly or indirectly, and we've got to either maintain lumbosacral alignment or lumbopelvic harmony, or obtain it with surgery. And so I think that's one thing that we teach now to our residents and fellows, is sort of looking at our pelvic incidence, our lumbar lordosis, seeing if we match it, and if we do, make sure we don't lose that or make the end plates parallel with surgery, but maintain lordosis. So I don't think necessarily in these cases do I worry so much about fixing the lateral translation if I'm going to operate on, but I want to make sure I fix the angular translation, so I at least keep them lordotic, don't lose lordosis, decompress the nerve, and then in this case with a mobile spondylolisthesis, is stabilize them with an instrumented fusion.
Sure. And Coy, if you just comment on just the general approach types for treating a spondylolisthesis, and kind of what you think the pluses and minuses are of those different types of approaches, and what your preferred one is, that would be
Sure.
interesting.
So for an L4, L5 spondylolisthesis, if the patient comes to me just with leg pain, I'll oftentimes just do a decompression, and I prefer to do those in a minimally invasive approach. If they come with both back and leg symptoms, then the options include anterior approaches, lateral approaches, as well as posterior approaches. Essentially for almost every one level spondylolisthesis case I do, I'll do it minimally invasively from the back, also called MIST-LIF, or transforaminal lumbar interbody fusion. I found this technique effective to decompress the affected nerves, stabilize the spine, and relying on the interbody work to promote a fusion.
Okay. And of course we're commenting on the restoring some lordosis or improving the sagittal parameters, and do you feel confident when you do the MIST-LIF that you can achieve those goals, or?
I do. I think a lot of the naysayers of MIST-LIF claim that it's a kyphogenic procedure.
Mhm.
I don't think that's actually been borne out in the literature. You know, Juan Uribe recently reviewed all the MIS TLIF and MIS lateral papers and actually found that MIS TLIF is not kyphogenic. It's not particularly lordosis inducing, but all patients got at least a couple of degrees. I think with a big unilateral facetectomy and a thorough discectomy, I'm usually able to get a good reduction of the spondylolisthesis and at least maintain the lordosis that the patient has.
And just open this up to the floor as we're kind of finishing up. As far as looking at the MIS TLIF versus an open, maybe a midlift type procedure, even an open typical posterior lumbar interbody fusion, you probably all done both. What do you think about the overall results for the patients?
So I think it's there are difficulties with both techniques. I think typically with an open decompression infusion, and say it is a TLIF, you get an excellent decompression. It's bilateral. Both lateral recesses, both foramen can be decompressed more than adequately. You can resect both facets, and you can get an excellent angular correction of the spine. The downsides, obviously, there's more bleeding and there's more damage to the back muscles. So those patients in my hands can get an excellent result of their clinical symptoms, but perhaps have a longer recovery, a little bit more back pain afterwards, and a little longer to recover. Again, MIS TLIF is an excellent option in the sense that if I can obtain the same result, get a good decompression, the patients also have an excellent outcome, but get out of the hospital much faster and back to work much faster. I think the downside or the difficult part with the MIS standpoint is you have to get an adequate decompression. So this patient needs a decompression. And through a tubular unilateral approach, if technically you can't get a good bilateral decompression, then these patients, at least in my hands, often have continued symptoms and are less happy with it. So it's an excellent operation, but it's technically a little bit more demanding, and it may be a little bit more difficult on the decompression standpoint.
And just to kind of wrap up and finish all the different approach options, I also find if a patient like this comes in where an indirect decompression, an anterior or lateral approach is an option, I do often consider it if it's anatomically feasible, because I find that I can get a nice graft in, a good biomechanical restoration of height, and kind of avoid dealing with nerves, which is odd for a neurosurgeon to say, but I've become more orthopedic in my old age. So.
But I think I agree with you completely. With someone who's reduced in the supine position, symptoms go away. All we've got to do is hold that patient in place. So I agree. I think either an anterior or lateral approach with percutaneous instrumentation, percutaneous screws, for example, is an excellent treatment for this. It's very minimally invasive. We have an excellent recovery, very, very short operation with few risks.
So I think, kind of in conclusion for everybody, I'd like to thank everybody for watching this session. But really, there's not a lot of strong data pushing you in one direction or the other. It really is dependent on what you're able to do in your hands as a spine provider, and maybe over time there'll be some more data that bears out that maybe there's less adjacent segment degeneration, those types of things with one approach over the other. But at this point, it's whatever you can do most safe in the most safe fashion. Thank you.